introduce Professor Zaffer Iqbal. Zaffer is Clinical Director of Psychological Services and Professor at the University of Hull, and has done extensive work on understanding and improving engagement with men. Over to you, Professor Iqbal.
Good afternoon. I have to wear glasses nowadays. It's very frustrating. Okay, so take as many pictures as you like of the slides. I'm happy for people to have a copy of the slides as a PDF as well. Okay. I want to start by saying that this talk isn't about blaming people, clinicians or services. I know it sounds ominous already. It's a talk about how our current system is designed and what that design unintentionally produces. My argument today is quite simple. Suicide prevention in the UK is fundamentally a problem of time, stigma, and how we treat suicidality once people do come forward. And if we're serious about men's mental health, we will need to look honestly at all three. And before I begin, I want to be transparent about a declared interest. I'm a trainer and senior consultant in the Collaborative Assessment and Management of Suicidality, CAMS. The Americans do not know about child and adolescent services. I do not receive additional remuneration and have no financial interest in the model. All that work is done as part of my NHS pay packet. I'm sharing this up front because CAMS will appear later as one example of a suicide-specific treatment, but not as the focus of this talk. And the argument I'm making today does not depend on CAMS or on any one example of suicide-specific treatment. That's not the focus of this talk. It rests on national data, patterns of help seeking, and what happens when people reach services too late. This is the statistic that should stop us in our tracks. 3/4 of people who die by suicide had no contact with mental health services in the year before their death. This isn't a marginal finding. It's consistent over years. The NKISH data tells us from 2010, over 15 years now, that even with the stability we have, there's no fluctuation despite changes in policy, service configuration, and even suicide rates themselves. This proportion barely moves. And this is very important because it tells us something quite clear. Most suicide prevention cannot rely on people already being within mental health services. If there's one idea I want you to take away from this talk, it's this. Time is the currency of suicide prevention. What usually happens is that people don't come forward when suicidal thoughts begin. They come when things have become unbearable. And by this point, for the help-seeking individual, hope is low, thinking is narrowed, and options feel exhausted. This isn't a failure of our crisis care, it's a failure of timing. The earlier someone feels able to speak about suicidal thoughts, the wider the window we have to help. The later they present, the fewer the options feel available, the harder it is to shift things. My proposal is that we reframe suicide prevention away from individual failure and towards how our system creates or constrains time. That means crisis services, accident and emergency departments, and acute psychiatric units who they're asked to reverse months or even years of suicidal distress in a matter of hours or days, are being placed in an unmanageable situation. Our systems need to widen the window of time by allowing help seeking earlier in the suicidality trajectory. And by doing so, we are providing a wider window for treatment, have more options, and less need for containment even. So, why don't people come earlier? Well, the research is very clear. Stigma plays a major role, but not stigma in the abstract. People fear being judged, seen as weak, treated differently. They also hold a deeply entrenched belief that nothing will help anyway. In men, this is compounded by norms around self-reliance and emotional suppression. We've heard about this all morning. And our review of the barriers to help seeking, which we did a few years back, similar to the work Professor O'Connor talked about, raised some interesting findings. Men ignore signs of suicide, self-medicate with alcohol or substances, and at the point of seeking help, some have even reported that professionals deemed their male suicidality as less severe. We need to highlight changes we are seeing in help-seeking patterns for suicidality. You'll see here that the suicide rate for men and women has risen, with the female rate at its highest since the mid-1990s. And while much of the day is focused on men, it is important to acknowledge this trend in women too. And evidence suggests that help-seeking experiences for women can also be shaped by stigma, dismissal, and social complexity. The NSPA's findings that women with poor mental health don't seek support from charities, online resources, or GPs, and grassroots over in America have linked suicidality to relationship difficulties, negative life events, abuse, and reproductive life course stresses. But buying time, how do we do it? And one of the most powerful tools we have is public health education. Not just awareness campaigns, but education that normalizes talking about suicide and distress early, before crisis. We've seen this before. HIV, AIDS outcomes improved dramatically when stigma was challenged publicly and people felt able to come forward earlier. Suicide is still where HIV/AIDS was decades ago. Something not talked about, hidden, delayed until it's dangerous. And public health education does not replace services. It gets people to them earlier and in a very different psychological state. I'm old enough to remember the HIV/AIDS awareness campaigns in the late 80s and early 90s. And their impact on public knowledge around safer sex, HIV transmission, reducing stigma, all of which led to earlier help seeking, better survival rates. Suicide prevention requires just such a strategy to give us the time to intervene. You know, when Princess Diana publicly held and embraced children living with HIV in the late 80s, she helped to dismantle a fear-based stigma in a way that no clinical guideline or public health leaflet could ever do. I am drawing this parallel deliberately, not because the conditions are the same, but because the mechanisms are remarkably similar. In the earlier years of HIV, stigma profoundly shaped behavior. People delayed testing, avoided disclosure, and often presented late, even though they cared about their health. Fear, shame, and anticipated judgment kept them away. And what is important is that stigma around HIV did not simply fade with time. It changed because of deliberate public health education, normalization of conversations, and visible evidence that effective treatment existed. Longitudinal and interventional studies show that as stigma reduced, help seeking increased. People tested earlier. You heard of clinical success stories. People engaged with services sooner because of them, and outcomes improved. And these changes were measurable over time. The point of the analogy is this: stigma is not fixed. It shapes when people come forward, and when we address it systematically, we buy time, and time changes outcomes. Suicide prevention faces a similar challenge. If we rely on crisis presentation alone, we are working at the very end of the window. Public health education doesn't replace treatment, rather it creates the conditions under which treatment can actually work. The lesson from HIV isn't just that stigma fell, it's that treatment only becomes effective once stigma stopped delaying treatment. And by the time someone reaches crisis services, we are often working inside days, sometimes hours, of a suicide decision that has been rehearsed repeatedly, even that day. Thinking has often narrowed to a point where suicide feels like the only coherent option available to them. So we are often working with suicidality that is not stable, but fluctuates across days and sometimes over the course of several hours. At this stage, suicide is often no longer simply a symptom. It has become a problem-solving strategy. It feels rehearsed, familiar, and even relieving to the individual. If anything, by the time people reach crisis, suicidality is volatile. The dynamic and rapidly changing nature of suicidality is well demonstrated by this depiction of real-time fluctuations. In this study, it asked over 100 adults to rate their desire to kill themselves every 4 to 5 hours each day for 28 days. And this was following discharge from an inpatient facility. Each line is an individual person. And it clearly demonstrates the challenges of reversing suicidality so late in the trajectory, when such thoughts can come and go this quickly. And over 95% of people had an instance in which their thoughts changed significantly between one point they rated and the next. So, even when people do come forward earlier, we often rely on treatments that were never designed to target suicidality directly. We assess risk, manage safety, and treat diagnoses. And we hope suicidality will resolve as a byproduct. Sometimes it does, but often it doesn't. I've already demonstrated how risk fluctuates sharply across the day, compressing the windows for engagement. How suicide shifts from a thought to a rehearsed solution, making change harder. And in our service in North East Lincolnshire, we often state, you have to be alive for us to treat your mental health diagnosis. This means we have to work together to reduce your suicide risk first. So time alone is not enough. What we do with that time matters. One reason why suicide-specific treatments, which do exist, why they struggle to demonstrate reductions in suicide deaths, is not necessarily lack of effectiveness, but the context in which they are delivered. By the time individuals present to services, risk is often acute and entrenched, as I've said. Time is compressed, and follow-up can be inconsistent. And suicide itself is a statistically rare outcome, which makes demonstrating mortality reduction in trials very difficult. And if we continue to engage people only at the point of crisis, we are evaluating interventions under the most difficult possible conditions. Earlier engagement may be essential if we want to see measurable population-level impact. This brings us to an uncomfortable gap in our system. Suicide is one of the leading causes of death, particularly for men, yet it has no nice guideline focused solely on suicide-specific treatment. This likely reflects the difficulty of demonstrating mortality impact in trials when interventions occur at crisis, as I've said, rather than it being a lack of recognition of the importance of suicide prevention. However, it means we still work to the belief that existing mental health treatments are sufficient. We have guidelines for cancer, stroke, heart disease, all focused on treating the primary problem. For suicide, we focus largely on risk management and indirect treatment. That's not because people haven't tried, it's because our system still struggles to conceptualize suicidality as something that can be treated directly. This isn't criticism of mental health treatments. It is a recognition that treating depression is not the same as treating suicidality. So, what does a suicide-specific treatment actually look like? It treats suicidality as the primary clinical target and not as a symptom to be managed around. It's collaborative rather than coercive, and it focuses on the personal drivers that make suicide feel like a solution to the individual. Importantly, it works across diagnoses, and it fits naturally with earlier intervention, exactly the space I'm proposing we create. There is exciting, burgeoning trial evidence for two forms of cognitive behavioral therapy for suicide prevention and brief cognitive behavioral therapy. However, this is where the collaborative assessment and management of suicidality, or CAMS, fits well, with 9 clinical trials to date and another 5 in progress across the world. CAMS is not a therapy in competition with others. It's a framework that makes treatment of suicide relevant. It has strong international evidence, a growing UK base, and has been shown to reduce suicidal ideation whilst improving therapeutic alliance and clinician confidence for men and for women. A recent German trial has even demonstrated a positive impact on suicide attempts. But most importantly, it aligns perfectly with the idea of earlier engagement, using time effectively rather than defensively. So, what does this all mean for practice? It means we need to intervene earlier, reduce stigma actively, and ensure that when people do come forward, we are offering treatments that directly address suicidality. It also means supporting clinicians, not just asking them to manage risk, but giving them evidence-based frameworks they can work with confidently. These are exactly the questions I hope we will explore together in the focus groups this afternoon. And I want to end with this. Suicide prevention doesn't fail because we don't care enough. We don't have rates from the 1990s because it doesn't matter and we're not trying. It fails because we intervene too late, and too often with the tools that were not designed for suicide. If we reduce stigma, buy time earlier, and treat suicidality directly, we already know how to do better. The question now is whether we are willing to redesign our system to reflect that. And my closing thought is there. If time is the currency of suicide prevention, we are currently spending it too late and on the wrong interventions. Thank you very much.